Good afternoon, and thank you for joining the RLS Foundation's webinar titled RLS in Pregnancy: Considerations for Preconception to Postpartum. My name is Adriana Colucci, and I'm the Communications Coordinator at the RLS Foundation. The RLS Foundation is using Zoom webinars for all webinar events. To ensure seamless webinar access, confirm that your Zoom app is up to date with the current software. If you need help accessing the live webinar on your computer, call the phone number listed on your registration confirmation email for assistance. If you have any other questions, please email kaleigh@rls.org, KALEIGH@rls.org. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions you submitted with your registration. The presenter will answer as many questions as time allows following the presentation. After the webinar, the recording will be available in our website's member portal section on the next business day. If you are not a Foundation member and would like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. All content, including without limitation, slides, handouts, videos, and other materials, are the property of their respective creators and as such are protected by copyright. They may not be reproduced, distributed, or otherwise used in any fashion without the permission of the creator. Our speaker today is Dr. Jennifer Hensley, an RLS expert and certified nurse midwife and women's health nurse practitioner. She built her clinical scholarship on restless leg syndrome during pregnancy and sleep disorders in women across the lifespan, and is currently a clinical professor at UT Austin School of Nursing. Dr. Hensley is also an active member of the RLS Foundation's Quality Care Certification and Medical Bulletin committees. Thank you, Dr. Hensley, for sharing your time and your expertise with us today. I now invite you to begin your presentation.
Thank you, Adriana. I hope that I will answer all of the questions that the audience wrote in during the presentation. And I want to thank you for joining for this very important topic. I have no conflicts of interest. Copyright notice. And before we begin, during pregnancy, you might need to educate everybody around you about restless leg syndrome. Your obstetrician, your certified nurse midwife, your certified professional midwife, your nurse practitioner, your physician assistant, and your maternal fetal medicine specialist, also known as your perinatologist. We would like to think that we're up to date on as much information as possible, and yet sleep is still a new medicine specialty, and restless legs is still poorly understood. Additionally, over the years that I have been doing this, most women do not volunteer during their pregnancy that they have RLS. Some might be afraid that what they're experiencing might sound like they're crazy. And for most of the others, it doesn't happen often enough to want to seek treatment, or they might just think that it's normal during pregnancy. So before we begin, please take charge of you knowing that you might need to educate your perinatal provider, including the nurses in the hospital, if you're going to have a hospital birth. It's been my experience that once you start mentioning that the professionals on the Restless Legs Syndrome Foundation board are from such places as Johns Hopkins, Stanford, Yale, Penn State, Vanderbilt, etc., that might be kind of an eye-opener for your provider once they hear these names that are leaders in research. We do have a pamphlet that is available on our website, Understanding RLS for Healthcare Providers, and you do not need to be a member to log in and download this. And it is a quadrifold flyer that has a lot of information updated regularly that you could pass out to your healthcare provider during your pregnancy. We also wrote a consensus statement about 10 years ago now, knowing full well that the information on restless leg syndrome was for the adult and pediatric population and not geared to the pregnant population or preconception. Now, 10 years ago might sound very old, and it most likely needs to be updated. But the other news is that I went out and cast a wide net and looked at what we had written 10 years ago, and not a lot needs to be updated. So most professional societies, when they come together and write a consensus statement, will say reaffirmed. And so more information on this to come, but I do believe that this is still current. And it's clinical practice guidelines for the diagnosis and the treatment of restless legs during pregnancy and lactation, because things are different during the pregnancy and during the breastfeeding time. All right. You might be asking, well, why don't we have answers to specific questions about RLS and pregnancy? And there's a reason. Pregnancy is considered to be a vulnerable population, and it would be completely unethical for us to say to two groups of pregnant persons, could you possibly take a medication that might harm you and or your baby while we give another medication or a placebo to somebody else? That would be completely unethical. We would not want to do that. So much of the information that we have about restless legs during pregnancy, we have gained retrospectively or looking at what happened in the past. We do know that during pregnancy, women are 2 to 3 times more likely to experience symptoms, and that it is more likely to be the second and subsequent pregnancies, and this doesn't matter what ethnicity you identify with. Risk factors include having a pre-existing history of restless legs, a family member, especially a first-degree relative, having had RLS in a previous pregnancy, being anemic and having it be iron deficiency anemia, with especially a low ferritin level, and anyone who uses tobacco or might be over 35 years. This doesn't mean that you will experience RLS symptoms. It just puts you at a greater risk. What is the course of RLS during pregnancy and postpartum? Experiencing the symptoms increases from the first trimester to the third trimester, which I will define in a moment. The highest rate of symptoms is in the third trimester, which is 28 weeks of gestation to delivery, and severity also increases from the second trimester through the third. And some women can experience more periodic limb movements. And just to mention again that there is an increased risk of developing RLS in a subsequent pregnancy and having it be a bit worse. The good news is that symptoms seem to resolve before delivery or almost immediately after delivery, and almost for everyone within 6 months. One of the researchers was looking at whether or not we could correlate the onset of labor with disappearance of RLS symptoms, but that didn't yield much information. And one of the questions from the audience was, If I have RLS in pregnancy the first time, will I experience it later on in life? Although there is a 4 times increased risk that that will happen, it does not have to happen. What are known factors that exacerbate RLS? Iron deficiency, prolonged immobility, and serotonergic antidepressants. And I will say more than once in this lecture, we should consider changing from perhaps Zoloft, Paxil, Prozac to Wellbutrin if clinically possible. These are the suspected exacerbating factors, which could be sedating antihistamines such as Benadryl, dopamine antagonists, and these are the antiemetics that we use during the first trimester of pregnancy. Sleep deprivation from obstructive sleep apnea or insomnia, sleep apnea that leads to hypoxia, lifestyle choices of caffeine, tobacco, and alcohol, pain syndromes, peripheral neuropathy, radiculopathy, and anyone who has had damage to a vein in the lower leg from a previous blood clot, and any inflammatory immunologic conditions. This is my niece. This baby is now 17 years old, but let me tell you some pregnancy changes that occur that might explain RLS or maybe just add more questions. First, we have 3 trimesters, and we do start counting pregnancy from the last menstrual period, which includes the 2 weeks before conception when nobody was really pregnant. But we do this to standardize talking to one another about how many weeks of pregnancy someone is, so that we know what is preterm and term and what we can offer during each trimester and what we should not offer. So the first trimester is up to the end of the 12th week. That is organogenesis. It is also the time most women present with nausea in need of medication, which first line of defense happens to be a dopamine antagonist that could perhaps exacerbate RLS. In the second trimester, the nausea vomiting of pregnancy is typically gone. Organogenesis is complete, but this is the time that maternal blood volume starts to double. And once your blood volume doubles, you're going to need more iron. And in the last trimester, 28 weeks to delivery, is the time that not only the uterus is growing, but the fetus is growing to 6, 7, 8, or 9 pounds. And in the last 4 weeks of pregnancy, the fetus is going to siphon off maternal iron stores because it has no other way to make red blood cells that are going to allow for an oxygen-rich environment when it takes its first breath. And in some part, maybe this is why the RLS symptoms appear. It could also be because of the pressure from the gravid uterus. But good news for RLS sufferers with symptoms during pregnancy is that during the 4th trimester or the first 6 weeks after delivery, RLS symptoms disappear, and it's quite a dramatic drop in the symptoms. Pregnancy changes include hormonal changes that lead to physiologic changes that then lead to mechanical changes. And for those thinking of getting pregnant who are pregnant, pregnancy is all about the fetus, and all of these changes are to assist with the growth and development of the next generation and give them the best first start in life. That might translate into what we call the common discomforts of pregnancy, that many of my patients call the common miseries of pregnancy, but it's all for you to get a healthy baby. These are the many hormones that all go into play during pregnancy. I do not have enough time to go through each one and what it does specifically, but let's talk about how this may or may not impact RLS. The culprit for nausea and vomiting of pregnancy is beta-human chorionic gonadotropin. From an anthropologic point of view, we think perhaps in the first 12 weeks of pregnancy, when the organs are developing, the mother may be nauseated so as not to eat or drink poisonous items that might have a bad effect on the baby. And that could be adaptive. And pretty much that's the only reason we can come up with it, other than what it does in order to signal other hormones in the body. But we know that the nausea then leads to seeking medication, and that medication might exacerbate RLS symptoms for the RLS sufferer. There isn't, and I tell my patients this, there isn't one part of your body that's probably not going to change a bit during pregnancy from all those hormones, from the tip of your head down to your toes. Did you know that your hair gets stuck in one phase of growth? It's beautiful during pregnancy. Then after delivery, the phases, 3 phases of hair growth come back and you might lose some. Water retention, which means that your eye orbits might get a bit swollen. It's hard to wear contact lenses. Many things change because of the hormones. And let me just move us out of the way for a second. There. Okay. Every system in the body is impacted by the hormones that lead to the physiologic changes, that lead to the mechanical changes, and the common discomforts of pregnancy, all to have a healthy fetus and a healthy baby. From a cardiovascular point of view, the estrogen and progesterone in the second trimester begin to increase the blood volume. First, the plasma starts to increase, and that's the clear portion of our blood, which means it's diluting out the red blood cells. And blood may actually double, or we can put it this way. If I have 5 liters of blood during pregnancy, I might end up with a minimum of 1.5 liters more, or actually more volume running through my system. Why? We need that extra fluid in order to push things through the placenta so that the baby gets what the baby needs. But that increase in the clear portion of our blood volume leads to a decrease in our red blood cells, which means our body needs to start turning out more red blood cells. Our blood cells that are red are responsible for carrying our oxygen. Well, in order to do that, we need iron in our body. And if we come into the pregnancy with an iron deficiency to begin with, it's only going to get worse during the pregnancy. And if we believe that in part of the pathophysiology of RLS has to do with iron deficiency, you can see where I'm going with this, and I'll talk more in a moment. Now, where do we store iron in our body? Our liver, spleen, our long bones, our duodenum, and our skeletal muscles. It is a protein and it stores the iron until our body needs it. And during this volume expansion of pregnancy, our body is going to need it. So the most bang for your buck during your pregnancy and before pregnancy is to get a ferritin level. We have normal levels for both male and female, but for RLS sufferers, it's the threshold is much higher. We need more for RLS sufferers than we do for the general population, because we need more ferritin, we need more iron stored in order to be able to push it through the brain, through the blood-brain barrier. Now, here's an interesting point. Pregnancy requires 1,000 milligrams of iron from our diet. And most of the time, what we have stored in our bodies is 300 milligrams. That would mean we need to find 700 milligrams for someplace else throughout a pregnancy in order for it to be healthy. More on that in preconception. Just to let you know, with this increase in blood volume does come an increase in the amount of blood pumped through the heart, which makes the heart resting rate go up just a little bit. You might feel a flip-flop, a palpitation. The heart does get a little bit bigger, but it's meant to, and then it will go back to normal size. But this also leads to some of the common discomforts because things get congested and fingers get tingly and swollen. And there's also much more blood being pumped through the kidneys, which changes our complete metabolic profile, which becomes important when we're looking for markers of preeclampsia during pregnancy. Most of the time for the complete blood count and the complete metabolic panel, markers are a little bit lower during pregnancy than expected during non-pregnancy. So you know, blood pressure drops during pregnancy, and this is from the progesterone that opens up the blood vessels. And then as the blood vessels open up and the plasma, the blood volume starts to increase, the blood pressure will come back to the baseline. But we do expect a decrease. And this accounts for some patients, or I'm sorry, some women feeling as though they get dizzy when they stand up until they get used to being pregnant. And hematologically, women develop more clotting factors so that at the time of delivery, there isn't a big hemorrhage. There is an expected blood loss, but not a big hemorrhage. And this part might be a mechanical, might have a mechanical relationship with RLS because relaxin, estrogen, progesterone loosens all the joints in the body in order to get the pelvic girdle just to, wiggle up just a bit more so that the baby can fit out more easily. But it's not picky. It relaxes all the joints in the body. But as a woman gets more pregnant with this more blood volume and this growing uterus, etc., it's now pushing on the lower legs, which is disallowing blood flow to come back to the heart and irritating nerves, etc., which in part may add to the discomfort in the lower legs associated with RLS. In fact, most women that I don't see a lot of RLS patients who are pregnant because many do not tell me unless I specifically ask. And I do specifically ask when women say I have problems with my lower legs, because most are going to think these are the leg cramps associated with pregnancy. And then when I do more better line of questioning, we figure out these are not leg cramps. This is RLS that is happening, and then we can have a different discussion. Just so you know where the weight gain goes, nobody's happy about putting on 25 or 35 pounds, in my humble opinion, but the weight goes everywhere. And by the time women come back to see me at the 6-week postpartum appointment, all the weight is lost but about 6 pounds, which is fat. And that will not go away easily until about the 6th month. We think maybe it's fat that the body holds on to in order to make good breast milk if there was ever a famine or a drought. So the medications that we often use during pregnancy that can exacerbate RLS. Let's go down to nausea gravidarum. Compazine, Reglan, the first choice always is going to be diclegis because it is a safe medication to give, but it is a dopamine receptor antagonist. And if you do have RLS and you do have nausea and vomiting of the first trimester of pregnancy, we do have an alternative, and that's Zofran, and it's ondansetron. And if it's cost prohibitive for you, a good RX will work. For insomnia, we often offer Benadryl because it is a sedating antihistamine, but other things can be used, not necessarily medicine-wise, but mindfulness or cognitive behavioral therapy for insomnia or other activities to help you do things until you get sleepier can work. Also, the seasonal allergies, especially here in the Austin area, what do we have again? Benadryl. We do have an alternative that should not exacerbate your RLS symptoms, and that would be Claritin. And there is a clear-cut association between maternal mental health and neonatal response to the mother in bonding and attachment. So any psychiatrist is going to tell you, if you have a major depressive disorder, we want to keep you on a safe antidepressant throughout your pregnancy or until things worsen. But if you also have RLS, we do have an option that is not a dopamine antagonist, and that would be Wellbutrin. Oh, we don't want to move. Adriana, can you advance for me?
Since since you're sharing your screen, I don't have access, but I can try pulling up your slides and sharing my screen instead. One second.
I'm sorry, everybody. Interesting. Okay, let's see if this works. Oh, we're stuck.
Do you mind hitting stop sharing your screen?
Let me try, go back.
But you can try that. No luck.
No, I'm stuck.
Okay, no worries. I'll share my screen and then. Oh,
Wait, okay. Here we are. Let's talk about preconception and restless legs. We do know from genomic-wide association studies that there are some genes that risk a person having RLS. One of our nurse researchers at UT Austin does a lot of gene studies, especially for traumatic brain injury. I will have more information when he answers my email, but there most likely will be a time when we can edit out this gene once we absolutely know which family has it. For preconceptually, we need to make certain that you get checked for ferritin and low iron stores in the body, because this is going to lead to reduced iron in the brain, which then, whether there's a dopamine deficiency or too much of a dopamine turnover, is going to be impacted by the amount of iron. For the pathophysiology of RLS, we might also have other transmitters that are not yet well associated with the actual disorder. We do know that anyone with peripheral pathology, such as multiple sclerosis, is at a greater risk. And estrogen, in 1 or 2 studies, has seemed to play a role. And one of the questions I got was about, well, definitely estrogen is very high during pregnancy. It is high during the first half of your menstrual cycle. And then after menopause, it's very, very low. So high estrogen, low estrogen, there's something in there. We don't have all the answers quite yet. When it comes to pre-pregnancy counseling, if you're going to go to your doctor, please already be taking folic acid. That's the #1 thing anybody would ever say to you. We want folic acid on board in your body 6 weeks prior to you conceiving to prevent a neural tube defect. 400 micrograms or 0.4 milligrams is over the counter, and you can find that in a Flintstone as well. However, if you do have a seizure disorder and are on medications or have had a history of a neural tube defect, you're going to need 4 to 5 milligrams daily. Prior to getting pregnancy, it would be the absolute best thing to make certain that there is control of hypertension, diabetes, and mental health. It would be prudent to have a conversation with your prescribing physician and an obstetrical provider about which medications are safer to take during pregnancy and switch, preferably 6 weeks before conception. Again, ferritin is the most bang for your buck. And if you are iron deficient, this is the time to iron replete with eating good iron foods high in and rich in iron, or taking an iron supplement, and maybe getting a vitamin D level to see if you're insufficient. Easy enough to look at that and take a supplement over the counter. Lots of, do we need vitamin D? Do we not need vitamin D at this particular moment? You could also consider pre-pregnancy genetic screening, having all your vaccines up to date. If necessary, checking for any sexually transmitted infections. And if you're too thin, or if your BMI is not showing that you are at an ideal weight, weight gain or weight loss, so that you can have a healthy pregnancy. Just Myriad is not the only one that offers carrier screening before pregnancy, but they are one, and they have 4 options. Check for only 4 things, such as cystic fibrosis, spinal muscular atrophy, all the way up to 269. Your insurance may or may not cover this, but if someone is a known carrier, they probably will. It would be a good idea to learn how to cook, eat, prepare iron-rich foods without destroying the iron in them now, and which ones taste good to you. Now, please bear in mind that the hormones of pregnancy may change that, and what tastes good now and smells good now may not. If you need a resource, you can go to dietaryguidelines.gov and establish an exercise regime. There's pretty much no exercise that the American College of OBGYN says you cannot do, especially early in pregnancy. Maybe scuba diving. And later in pregnancy, you probably don't want to go skydiving either. But a minimum of 150 minutes of moderate exercise per week. And then we wrote a consensus statement, and Hale's medications for and Mother's Milk and Briggs have been on the market, or not on the market, have been resources for decades to let us know what's safe in pregnancy looking backwards, and what we can give during the pregnancy itself and lactation. You can get our consensus statement and a copy of it to give to your provider if you email us at rls.org. And we came up pretty much.
Dr. Hensley, you're muted.
We came up with a consensus statement to help providers know how to diagnose it, what to do first, such as with non-pharmacologic options, assess the iron is always going to be number one, and then get more iron on board, knowing that the blood volume will double. And we can replete that iron by mouth, taking iron supplement once a day, orange juice not necessary. But if someone comes into the pregnancy with RLS, then we can move down to more options that are medication related. And having looked, it took us 2 years to write this, and having looked at all of the literature that we could find, knowing which is the safest for the pregnant woman and the fetus. I'm stuck again. Hang on.
You got it.
You know, you could be my students, the participants now, and this would never have happened. But because this isn't being recorded for a national storage, of course it's going to happen. All right, let's just get to this. When it comes to complementary modalities, we also looked at a number of things. Mental activity. Well, there's insufficient evidence. Near infrared, insufficient evidence, and you can buy these infrared pads on Amazon, but nitric oxide is generated and it produces vasodilation, and anybody is going to say during pregnancy, use with caution, or more so, they're going to say, talk to your provider. And of course, your provider is going to say, I don't know. And that's the time you can bring out the consensus statement. So the near infrared therapy pad is, there's not enough evidence during pregnancy. There's not enough evidence in the adult population, and there are some efficacy and safety concerns. Pneumatic devices, those are the sequential compression stockings that we put on someone during a cesarean birth. Those might help, you know, because they open and close, and they also prevent a deep vein thrombosis. One thing off the market is a vibration pad. I went looking for it about 6 months ago, and Medicare decided that it was cosmetic and not a device, and the company took it off the market. I don't know why sexual activity would be an efficacy concern, because we all know that the endorphins triggered by that can give momentary relief for just about anything. But on the other hand, if you are an RLS sufferer and it goes on for hours and hours, this type of exercise might be taxing if it was continuous. Hey, you could engage your mind with social media. Just make certain that you turn the blue light source off an hour before sleep. Otherwise, it can kind of muck up your circadian rhythm. Pneumatic compression stockings, devices, you can get them either cheaply or very expensively. And then when we think about actual medications and pharmacologic options, we have this little saying, low dose, slow increase for the shortest amount of time possible. Since most RLS symptoms are going to begin in the 2nd and the 3rd trimester, it's actually a better time because the baby's organs have formed and there's less of a chance of teratogenicity. And when we consider a treatment option, we're looking at how severe is it, how often does this keep you awake, what are the risks and the benefits. it would be perfect to have an OB provider and a sleep expert or your PCP talking to each other, or at least you bringing information from one to the other, and the consensus statement might really help them. So again, the ferritin level paid out of pocket is probably $75. If it's less than 75 micrograms per liter and you have RLS, there's no reason during pregnancy that you shouldn't start your own iron tablet once a day. You don't need to take it 3 times a day. Your body only absorbs so much iron per day, and you don't need to take it with orange juice. But please do not take it with any dairy products, milk, cheese, yogurt, because iron and calcium bind together and they're eliminated from the body, and you won't get either one. Now, IV iron sounds like it is the easiest thing to do, but although the side effects are rare, they can occur. The bigger issue is having an insurance company pay for the infusion if your hemoglobin is not less than 8.5 and you have symptoms. So for the insurance company, they don't always go based on your ferritin level or your RLS. They're going to go more on the hemoglobin and raising the hemoglobin. But if your OB provider and your sleep expert or primary care person actually has an opportunity to write a letter on your behalf to the insurance company, this might get the transfusion based on the RLS symptoms and not an iron deficiency code. Now, we also looked at what we could give during lactation, because Mirapex and Requip are dopamine antagonists, and they will block prolactin, and that will stop milk production. And we don't want that to happen, because breast milk is best to give a best first start for the baby. Now, everything in the consensus statement is based on what we call a relative infant dose, and that happens to be how much any particular drug can be measured in breast milk. So anything less than 10% is safe. And if we can stay away from any medications for the first 2 months postpartum, that would be better, because there are fewer adverse effects on the baby as the baby gets older. So any opioid is going to be a really red flag, hot topic kind of thing. And I'm just going to put this on the back burner for somebody who has refractory, horrible, terrible RLS, because it's hard to prescribe opioids in the adult population. It's even harder to prescribe opioids in the obstetrical population. But if there is refractory RLS during pregnancy, we could use clonazepam, which is a benzodiazepine low dose, or levodopa carbidopa. This probably will come from your obstetrician or your nurse midwife only after we get a letter from your sleep expert or primary care provider. And during lactation, we want to make certain that your iron status is getting better, because remember, now you get to keep all your iron. Nobody's going to siphon it off. The baby is on its own to produce and collect its own iron. Now we can use gabapentin, which we can't do during pregnancy. Now we can use trazodone, which we could not use during pregnancy. And this is safe during lactation because the RID for gabapentin is up to 3.8 which is less than 10%. So the baby will not get much of this in the breast milk. And again, in trazodone, for those with refractory RLS, the RID is 0.6%, which is far below the 10%. So in general, we need a diagnosis. Your obstetrician needs a diagnosis. I'm happy to write one for any midwife. And your certified nurse midwife should know, because there was a time that they had to read my article, and at our professional conference meetings, I talk about this every single year. So there's no reason that nurse midwives should not know about restless leg syndrome. Know that it typically occurs and gets worse, especially in the third trimester. That is after embryogenesis or when organs have formed. So then if we need to talk medication, it's safer. And if not before delivery, immediately after delivery, almost all of the symptoms will resolve. And we want to base any treatment that we do on what your quality of life is like, how you are sleeping, because short sleep can lead to a longer labor. We have some studies on that. We do want you to sleep. And we also want to use a medication that's the safest, the lowest dose, go up as slow as possible, and use it for the shortest period of time. Now, I have had a couple of patients who, for number 9, just felt better knowing that they were not going crazy, that their symptoms actually were real. And they said that they could live with it. And here's how I got started in all of this. It was a Friday afternoon at 4:45. I had 2 patients to see. I wanted to go home, and both of them complained of lower leg pain. So we talked about the fact that it's probably leg cramps. I told them to take some magnesium, which everybody does. And then I went home, and the first commercial was a Mirapex commercial. And it occurred to me, I'll bet you these 2 women that I saw do not have leg cramps, but they have RLS, and we providers are asking the wrong question. So I am on a quest to get everybody to ask about this. And now you know that we have resources for you to take to your provider to help educate them.
Excellent. Thank you so much for such a thorough presentation. You covered a lot of material. Many of the questions that were submitted were answered, but we're just going to kind of go through a couple of the ones with our remaining time. So first, can you address the question, could low iron or could my RLS medications be a factor for issues conceiving?
Severe iron deficiency anemia could be. It's more so associated with preterm birth. There are a lot. So my first thought is probably not. I'm wondering. There's a whole workup of questions that we ask based on age. How old are you? How long have you been trying? We want to know how you try. Believe it or not, there are some people who don't have sex at the right time of the month. But unless your medications are causing you to not ovulate, most likely not. And of course, I'd need to know what the medications are, because we want to change any meds that could be teratogenic to the fetus.
Okay. Are there any overarching general things I can do to prevent or minimize RLS during pregnancy?
Yes, if I didn't talk enough about how to, okay, first of all, most women come into the pregnancy thinking in the next year I'm going to get pregnant, and then it happens sooner. So most women are not ready. Okay, it just happens and you're like, wow, that was a surprise. One, if you are planning a pregnancy and you have severe RLS, iron replete, go now, get a ferritin level. Start eating foods that are rich in iron. Okay, and start an exercise routine that you think you can carry through your pregnancy, because we know that exercise releases endorphins, makes us feel better, and helps us sleep. Can also has been known to minimize some RLS symptoms, probably from the endogenous opioids.
How can I educate my OBGYN about RLS? My symptoms are dismissed when I bring them up.
Yes. I've been laughed at by my colleagues. That's pretty not okay, I think. We have the pamphlet that you can download without being a member. And if you email Adriana, you can have the consensus statement. And I am thinking that once your provider looks at Mayo, Yale, Johns Hopkins, etc., there's going to be a little thing that goes, oh, these are not quacks. These are real physicians and PhD researchers who are looking into this. Maybe I should read this consensus statement, because it's not just about what medications are good during pregnancy and lactation. There's also how to diagnose it and the pathophysiology of it. And now that we can find it on genomic-wide association studies, there's no denying it.
If you need access to any of those resources, just email me, Adriana at rls.org, and you can see my email in my name description, or info@rls.org, INFO. And we would be happy to send that to you. If I developed RLS for the first time during pregnancy, does that mean I am more likely to develop it later again in life?
Yes. You have a 4 times increased chance of developing RLS as an adult and a non-pregnant person. But that also doesn't mean that you have to. Exercise, iron, and
Can I pass RLS on to my child?
we know that, so that's not a cut and dried yes and no, because we have found the genetic markers on more than one spot. So the answer is yes. In part, it's genetically transmitted, but it is not fully understood. Now, 10 or 20 years from now, I think we will know a whole lot more and might even be able to edit that gene out.
Why does RLS start in pregnancy and then disappear after, yet returns midlife and then does not disappear after that?
I wish I had a good answer for that. If RLS has to do with iron deficiency, and it has to do with dopamine, maybe, or maybe us metabolizing dopamine too quickly, we think in pregnancy, could it be due to the iron deficiency part, because the blood volume expands? Or is it from the estrogen? What we don't know. But it would make sense, because the minute the placenta is born, that the thing that is producing all that estrogen is gone, and all of that extra blood volume is going to have to be eliminated by the body. And that's why women are up to the bathroom almost continuously the first few days after delivery because the body's getting rid of all that extra fluid. But as we age, that's difficult because we collect comorbidities, osteoarthritis, etc. And as in menopause, our estrogen level is low. So I'm not certain how estrogen fits in there, but perhaps to take care of the comorbidities like hypertension, hyperlipidemia, diabetes, etc. Maybe some of the medications to help those might have an impact on the RLS, or is it more of our immobility? You know, we're just not as active as we were when we were young. I'm not certain that we have a clear-cut answer for that. Aging, as we know, is not for sissies.
But are there risk factors that make one more susceptible to developing RLS during pregnancy?
Medications, the ones that we talked about during the presentation that antagonize dopamine, Benadryl, diclegis for nausea, many of the antidepressants, and low iron stores. I often will get a patient whose complete blood count looks perfectly normal, but when I draw the ferritin, rather than being above 75, it might be 7. Which tells me if it's early in the pregnancy, all of that iron stored is going to be sucked up. And if she happens to be at risk for RLS symptoms, they could quite possibly appear.
Okay, we'll do one last question. So what medications are safe for use in pregnant women with RLS? And does that list differ from pregnancy to labor and postpartum?
Yes, and the consensus statement is the best that we have. So during pregnancy, safety first, iron repletion. Okay, we want to get that iron up, see if that takes care of the symptoms. I can guarantee you in labor, you're not going to be thinking about RLS when you're having contractions, but there are some antiemetics that we give that antagonize dopamine. Tell your nurse and tell the anesthesiologist if you are going to get an epidural, I have RLS, please do not use these medications. And of course, if you have a specific question, you can email us and I can certainly answer what those anti-nausea medications might be. And remember, postpartum, the symptoms for most seem to disappear, like poof.
And the foundation also has medical alert cards that list those medications that will trigger. And it's really small, you can keep it in your wallet. So if you need a copy, please email us. So I want to thank you, Dr. Hensley, for joining us for today's webinar, and thank you to all who are listening. We hope to see you on Wednesday, November 13th as well. We are hosting another showing of our highly requested 2024 virtual summit, where you will have the opportunity to hear from featured RLS researchers who discuss their current findings and explain what they hope to learn about RLS through their studies. It's a full day of learning. If you need more information on that, please go to www.rls.org. And you can go ahead and purchase your ticket on there. Thank you again and enjoy the rest of your day.